Good afternoon, everyone, and welcome to today's webinar on vaccines and EU HTA regulation. My name is Anna Vicere, and I'm Associate Director for Access Policy and Public Affairs at Vaccines Europe, a specialized group at FPA representing innovative vaccine companies operating in Europe. So if you have joined this webinar, it means that you have probably heard something about the EU HTA regulation. However, how familiar are you with its implication for the future vaccine assessments across the EU? Well, this is something that we will try to explore with you today. Our agenda, which is on the next slide, is divided into three main sections, which hopefully will respond to some of the key questions that you have at the back of your mind. So first of all, we will focus on what is the EU HTA regulation and what are some of the vaccine specificities that should be recognized therein. Second section is responding to the question why vaccine innovation is so vital and why we should not wait more for considering vaccines within this new regulation. And then the last section will respond to the question how the processes and methodologies set up by this regulation should be adapted to account for the vaccine specificities. So before I hand over to our distinguished speakers, I would like to remind you of some housekeeping rules, let's say. So first of all, if you would like to ask a question to the speakers, please use the Q&A button below. On the other hand, if you encounter any IT issues, use the chat so that our team can help you to solve your issue. Please also note that the webinar is being recorded and will be shared later on at the Vaccines Europe and FPA social media platforms. I hope this is all clear. So without further ado, I will hand over to our first speaker, Professor Chiara De Voor from the University of Perugia. She's also president of the HTA section at the European Public Health Association and the co-chair of the HTA Public Health Interest Group. Chiara, the floor is yours.
Thank you, Anna, and good afternoon, everybody. I would like to thank Vaccine Europe for inviting me to join today as a speaker. And my task is today to set the scene of the HTA regulation. So I would like to start, next slide, please, with a jump in the past, because Europe has a long-lasting collaboration on HTA that has been started last century, as you can see, with the Euraccess project, and then continued during this century with the well-known project that is named European Network for Health Technology Assessment, UNETA project, that has released very important tool for the standardization of HTA reports. And then was followed by the joint action 1, 2, and 3 that supported the European collaboration in terms of sustainability also. So this has led, next slide please, to the discussion about the EU regulation on HTA. The work that has done has made it possible to have this regulation has been very long, because it lasted approximately more than 3 years with a discussion among the European Commission, the European Council and the Parliament, and the entrance into force in January 2022, as you can see. The main goal of the HTA regulation is to speed up access to medical products across Europe by reducing the application and also improving the resource use in developing HTA reports, but also improving the quality and transparency of the HTA evaluation. So next slide, please. The HTA regulation is a very relevant document because it established the need for having joint activities on medical products as well as high-risk medical devices. These joint activities are indeed joint clinical assessment and joint scientific consultation, but beyond these two types of assessment, the regulation also foresees the possibility to work on identifying emerging health technologies, that means horizon scanning activities, to develop also methodological guidance, and this is very relevant for vaccines, but also having voluntary collaboration in respect to those non-clinical domains that are not in the scope of the joint clinical assessment and joint scientific consultation. So next slide, please. In respect to the implementation of the regulation, you can see that at the European level, there is a very robust governance of the process because you can see that there is a coordination group with representatives from the different member states. And within the coordination groups, there are also subgroups that are dealing specifically with joint clinical assessment, joint scientific consultation, the identification of emerging technologies, and methodology, both in respect to medical products and medical devices. There is also a secretariat. There is an HTA IT platform that is meant to allow the sharing also of documents for the implementation of the joint clinical assessment and joint scientific consultation. And there is also an HTA stakeholder network that is an organization, a body that has been established with representatives from different stakeholders, including companies, academia, patients, clinicians, and healthcare providers. So next slide will guide us to understand what is meant by joint clinical assessment, that is the core activity that is foreseen by the HTA regulation. Joint clinical assessment is a comparative analysis, as you can see, of available clinical evidence on health technology in comparison with other technologies, so alternatives, that is focused on clinical domains. Here you can see the UNETA core model as reference, in which there are 9 domains considered, and these first 4 are the so-called clinical domains that are health problem and current use of the technology, description of the technology, safety, and clinical effectiveness. Nevertheless, as you can see on the right side of the slide, there are also non-clinical domains that are pertaining costs and economic evaluation, healthful analysis, organizational aspects, patients and social aspects, and legal aspects that will be considered at member state level, because as you can see from the slide, the joint clinical assessment should be given due consideration by member states that will be entrusted to exploit the value of the technology, considering the local context, so non-clinical domains. Next slide, please. In the implementation phase of the HTA regulation, before the January of this year, in which the regulation is becoming full operational, there were different implementing acts that were published. So next, please. Here you can see the list of implementation acts that were published that are more operational documents highlighting how the process has to be conducted in respect to both medical products and medical devices. You can see that there are also some implementing acts in respect to the exchange of information with the European Medicine Agency and also on the management of the conflict of interest. In respect to the timeline of the implementation, regulation starting from this year. New oncological medicine and advanced therapy medicinal products will be under the scope of HTA regulation. From 2028, orphan medical products, and from 2030, all new medicine, including vaccines. Next slide, please. What about vaccines? Well, the regulation mentioned vaccines, but in a very small and brief paragraphs, in which there is the call for a methodological guidance in order to understand and to investigate the specificity of new health technologies, such as vaccines. So it's a task of the coordination group to develop this methodological guidance, and this is very important, also considering that even though vaccines will be under the scope of HTA regulation from 2030 in terms of joint clinical assessment, there is already the possibility to have a joint scientific consultation by companies, asked by companies, but also horizon scanning and voluntary collaboration. So, next slide. The final consideration that I would like to bring to you is that it's sure that we need methodological guidance in order to make it possible to apply the HTA regulation to vaccines and cover all the specificities of these technologies. And here you can see that methodological guidance are of utmost importance, in particular because beyond needing standardization of the evaluation, we should avoid that member states request additional information data that are not submitted in the joint clinical assessment, because as I told before, the objective of the regulation is to speed up the access to medicines so that member states can easily go to the evaluation of our non-clinical domains. And another important aspect that I want to touch on is the evaluation expected in 2028. Because in this year, the European Commission will collect feedback and suggestions for improvement. And this is a very important opportunity that has not to be missed in order to give suggestion on how to approach to vaccines in order to be able to evaluate in joint clinical assessment this new technology starting from 2030. So thank you very much for your attention.
Thank you very much, Chiara, for this clear introduction. I think it's very challenging to summarize everything that the EU legislator have done over the past years to come up with this regulation in 10 minutes. And it was indeed very interesting to hear also what are the origins of this regulation and how it will look like in the nearest future. We have one question that was asked in the Q&A, and we have a couple of minutes. Maybe we could try to respond to it. So in the context of comparative analysis, and you have touched a bit on the methodologies as well, even when addressing a severe and rare public health issue, should we still consider the classic comparative analysis method, double-blind randomized controlled trials, as the gold standard for assessing the validity and precision of clinical evidence? No, it's quite technical, so let me know if you want to take it or respond in writing.
Thank you for this very important question that in this is very topical, also because among the guidance documents that were released just last year, there was a methodological guidance on indirect comparisons, because we all know that the regulation implies that we cannot rely just on randomized controlled trial. This is true for all the technologies, not only vaccines. So this document is very important because It highlights methodologies that are currently adopted for indirect comparison that can be trusted in order to have relative effectiveness data and also relative safety data.
Thank you very much. That was clear. In that case, I think we will move on to the second part of our webinar, where we will focus on the question why. So why vaccine innovation is so important, and we're speaking about it now and not necessarily waiting until 2030 when the regulation will be fully in scope for the vaccines. And I'm pleased to introduce Professor Martin Postma to try to respond to this challenging question. Martin is a professor of global health economics and pharmacoeconomics at the University of Groningen in the Netherlands, as well as professor at 2 universities in Indonesia, which name I will not try to pronounce. And he's also importantly a current member of JCVI, which is essentially NITAC in the UK. And that's very important also for our later discussion on the role of the NITACs. Martin, the floor is yours.
Thanks, Anna, for inviting me. And I will talk a bit more about the specificities of the vaccines and the need to act now because there is a pipeline coming and of course also some urgent issues we have seen in the last years. And apologies, I'm doing this from the car. I had a delay with the plane from Vienna ECMID conference. Can I have the next slide, Anna? So I will start a bit with RSV. I will talk about also the CMIP as the methodological backbone that we use in the joint Joint Committee of Vaccination and Immunization in the United Kingdom. And I will say a little bit more about the broader impacts that vaccines have to further stress the need to do an adequate evaluation of these kind of products. Next slide, please. So this is the last one of the most recent assessments of the JCVI. This was on RSV in adults, and we know that in particular in the United Kingdom, cost effectiveness is a very important criterion in the health technology assessment for JCVI, and there were actually in this case 2 models underpinning the potential favorable cost effectiveness of the of RSV immunization in older adults, and actually one was from the group in Groningen. Yeah, thanks. And then one slide back, please, if possible. Yeah, thanks. And also in the final decision or recommendation, indeed, cost effectiveness was the main idea here. Why first to limit to 75 years and older. Next slide now, indeed. Of course, there are differences in health technology assessment. That's also why we need more collaboration. Of course, we can always ask how far can we go with collaborations, but United Kingdom, of course, a typical in blue here, a cost effectiveness country. Whereas for the other country that I'm very familiar with, the Netherlands, in green, reflecting a more multi-criteria decision type of approach where cost effectiveness is a subsidiary argument, but there is also, for example, budget impact that is an important one. Next slide, please. And bugs have no borders. To an extent, expect similar types of schemes in different countries, but this is, of course, not the case, and to a certain extent surprising, and again stressing the need for collaborations and to act within the context of the JCI. This is the Netherlands and the UK. On the left, Netherlands, no advanced influenza vaccines in the program. UK does. It was actually based on real-world evidence that was addressed previously by Chiara in her answer. no shingles in the Netherlands, and of course in the UK, yes, RSV older adults, not in the Netherlands. Actually, just a negative advice last week in the UK being implemented, and then also meant B, a big difference. Next slide, please. And indeed, this is RSV, but there's so much coming. By the end of August 2024, as the slide reads, there were 98 vaccine candidates in the pipeline. And this is of course, influenza, COVID, combination vaccines, but also bacteria, other viruses, etc., etc. Next slide. So in the JCVI, the backbone in the methodological part, and we need further collaboration in this field as well, was this report, the so-called CMIP report. Next slide. And I want to highlight two things in this report. The first thing is, how adequate is the EQ5D, the quality in the field of vaccines? And it has its problems. It's sometimes difficult to measure. A bit more about that in my next example. And if it's measured, in this case, it was done for MENT B, we have to feel that it doesn't grasp everything. And actually, next slide, in the JCVI advice on MENT B, this paper was very influential. And let's go to the next slide to see what they actually argued, that for MENT B, there is this concern over whether the EQ5D could fully capture the long-term losses of utility in survivors and meningococcal disease, and maybe more even in general, how adequate it is for small children. So actually, in this case, a quality of life adjustment factor was applied to correct for potential underestimates that the EQ5D may do in vaccines. Next slide. And then we recently did this project in the European Union, and yeah, the EQ5D is sort of the and this was in respiratory disease, and it was in general practices. It was about reducing the antibiotic prescriptions by doing better testing. But I don't want to go into the intervention itself. The EQ5D is the holy grail for health technology assessment. So it is, in a way, very important that we also have good data for infectious diseases. And within the context of this project, we were able, among thousands of participants, to actually apply the EQ5D in respiratory infections, where data are extremely scarce on quality of life measured by EQ5D. Next slide shows the result on yeah, this is the EQ5D. Let's go to the next slide. We all know how the 5 dimensions of the EQ5D, how they work. And of course, after we have the 5 dimensions, we use the tariffs to translate to different countries. And now we have this overview of an episode of influenza, for example, that goes to the GP, and what actually the disutility is. And as we know, it differs per country, because the tariffs differ per country. So the EQ5D typically comes out, in this case, very differently in the UK than, for example, in Poland, at the other extreme. Next slide. Another thing I want to highlight is very, again, specific for vaccines, and a big need to act. We invest now, and the benefits are in the future. And so important, how do we value future benefits? And there, our so-called discount rate comes in. Next slide, please. Initially, we assessed in the United Kingdom the HPV vaccine as not cost effective. There was summer 2017. And then, next slide, a year later, we read the analysis, and it shows how influential, because it reads that we applied a different rate to assessing the vaccine, and it was meant a different rate to assessing a different discount rate, and how enormous influential the discount rate is. So again, here, vaccines have its specificities. Next slide. And we're going towards the end, no worries. So we talked a little bit about quality of life in green. This is what is called the value flower, all the values that drugs and vaccines may exhibit. And the other thing in green is about costing, where indeed discounting is very influential. But there's so much more values, and therefore so important to collaborate and to act now with all the pipeline vaccines that are coming our way. Next slide. To show for vaccines, there are scientific spillovers. mRNA can be very broadly applied. There is a peace of mind effect that we never take into account of vaccines. There is potentially an enormous economic benefit. Think back of the macroeconomic effects that the COVID pandemic had. We don't talk a lot yet about it. It was a topic in ECMID in Vienna. How can vaccines avoid AMR, antimicrobial resistance? They only have sometimes often a modest budget impact. So that can also be seen as basically a value of vaccines. And finally, it often has effects beyond the person vaccinated, but it has population type of effects. That's why we also need these more complex, what is called dynamic models when we look at the epidemiology and the cost effectiveness. Next slide. Brings me to my summary. And I've already said many times, collaboration is needed. There are different schemes, which is in a way surprising in Europe. There are different methodologies. There is a big need here to work on that. Vaccines have the specificities. It was also already argued by Chiara. I illustrated a bit about the difficulty with quality of life and the issue of benefits taking place far in the future. Broader impacts are not yet consistently included. Think of peace of mind and AMR. And then finally, in the next slide, let's hope that the joint clinical assessment can help in this collaboration on these several fields while taking into account the specificities that the vaccines have. Thank you very much.
Thank you very much, Martin, for this presentation. And I think especially your reflection on the broad value of vaccination was very interesting. And yes, how we can appropriately capture that also within the EU HTA regulation is another question that is on top of our minds. There were a few questions in the Q&A, but I'm conscious of time, so maybe we will have an opportunity to catch up on them later during a big Q&A session that we will have. So I will move on to, thank you. So I will move on to the last section on how. And here, before I hand over to our speakers, I would like to make a short introduction, because indeed the three speakers that you will hear from now are actually representatives from the Vaccine Europe Market Access Working Group, and will present the outcomes of the study that we have been working on for a couple of years. And last year, in fact, we did a publication in a peer-reviewed journal, Value Health, which was actually co-authored with leading experts in vaccination from across the EU countries. So as part of this publication, we have identified 3 guiding principles and 13 recommendations on how to, in fact, ensure that the EU HTA regulation is adapted to vaccines. The first principle is focusing on the methodologies. The second one is on processes and expertise. And the last one relates to the data collection and real-world evidence. So now, without further ado, I will leave the floor to our first speaker. So Paolo D'Agostino, who is a Global Market Access and Pricing Director at CSIS Securius, and he will present a case study on why actually we need specific processes and expertise for vaccines in this joint endeavor. Thank you very much.
And thanks, Anya. Good afternoon, everyone. And let's jump immediately into the first slide. We want to start analyzing the importance of aligning the new joint clinical HTA activities with existing and already quite complex vaccine access pathways across Europe. So those pathways are highly heterogeneous from country to country, and compared to vaccines, vaccines go through even more steps and involve a wider range of decision makers. One key difference, for example, is the role of NITAGs that our colleagues were basically discussing before, the National Immunisation and Technical Advisory Groups. And as you might know, those are expert bodies that review evidence and advise whether a vaccine should be included into the National Immunization Program, the so-called NIP. Every country has its own NITAG, and the input that they provide are critical. Based on a previous analysis done by Vaccine Europe, I think last year, in 14 out of 17 countries, NITAGs work in tandem with HTA bodies, which often conduct their own evaluation to support and pricing reimbursement at the local level. So the big challenge is that many HTA bodies still apply frameworks designed for medicines, but not specifically for vaccines. As a result, a critical factor like public health impact or outbreak prevention are not often properly considered. Today, from that analysis, only 4 countries like France, Ireland, Sweden, and Italy in the European Communion, they use a HTA framework specifically adapted for vaccines. And this could lead to major variation across Europe, both from the quality of the assessment and their value in their decision-making process. So now with the future introduction of joint clinical assessment at the European level, we are adding a new step of complexity, a new layer, primarily led by HTA bodies, and most of them seems that could lack a deep experience in vaccine evaluation. So that's why it's essential that the joint assessment are integrated within the existing national systems led by NITAGs that can really understand the local context, and they know how vaccines are actually used and assessed at the country level. Next slide, please. So as a Vaccine Europe, with other colleagues, we were basically looking at the situation, and we are confident that what we are trying to advocating today is the right path, since the HTA regulation already provides a solid foundation for this approach. And Chiara was mentioning already the section in the Article 4, and I'm reading here, for example, when creating procedures for joint assessment, the coordination group must consider the specific feature of the health technology being assessed. So the vaccines are not medicine in a certain way, and this is clear. They are used for healthy population. Vaccines are used for to prevent a disease before it happens. And the effect goes even beyond the individual, such as the herd protection, the herd immunity, it's called herd immunity, bringing fewer hospitalization and less pressure on the health system. Because of this, it's essential to have the right kind of expertise involved in the assessment. And this is exactly what NITAG can provide, looking at the clinical data, but also the public health value for vaccines, how they fit into the National Immunization Program. Their input, we are pretty sure that make a joint assessment more relevant and more likely to be used at the country level in the decision making. Next slide, please. So just to reiterate the need for the involvement of NITAGs into the HTA framework, this is essential to achieve the goals that was basically already defined into this HTA framework. The first objective from that has been clearly defined was to strengthen the scientific quality of the HTA across Europe. And this could be done with the NITAGs, involving them in a structural and formal way, with the structural and formal involvement within all the coordination group, all the activities that can help clarify the role in the national assessment and the appraisal process. The other pillar, in a certain way, would be to include the NITAX member into the process as assessor or co-assessors in the joint clinical assessment and joint scientific consultation. And we can definitely strengthen the scientific quality of the assessment while expanding the overall capacity, having both pillars that I just mentioned before. The second objective is to prevent duplicative efforts and support national authorities. So this can be done making more informed and timely decision, but the activities that we were trying to suggest is to provide targeted trainings in order to build a shared understanding how the HTA regulation is working and its application to vaccines. And finally, enabling early NITAX input into the scoping process, ensuring a more relevant assessment, prevents duplication, and support more informed and timely decision at national level. So just to close with this slide, we wanted to propose 4 pillars, 4 key activities that can really support that vaccines are timely available in Europe. So thank you, Anya. That was my presentation, and I'll leave the floor to you.
Thank you, Paolo. Thank you very much for outlining these differences between vaccines and medicines, and indeed the critical role that NITAX play in the vaccine assessment currently in most and all of the EU countries, actually. So now I will leave the floor to Eliana Biundo, Senior Director at GSK, to present another case study, in fact, on the need for vaccine-specific methodologies. And Eliana will speak much more on the scoping process, which Paolo briefly mentioned in his presentation. Thank you.
Thank you, and good afternoon, everyone. I'm glad to be here. If you go to the next slide. So speakers before me, Professor Devouer, Professor Posma, they all already started alluding to the fact that there is a need for having specific methodologies that account for vaccines differences. What I would like to do now is maybe to go a bit more in detail and really looking at, okay, how does this joint clinical assessment actually going to work? And let's say, if you want, the engine of the joint clinical assessment is going to be the PICO. So basically, the PICO will be the tool through how these comparative assessments will be done based on the available clinical evidences. So if we look at the PICO, so PICO stands for population, intervention, comparator, and outcome. Basically, the PICOs will be agreed by the coordinating group and proposed by member states. If we look at the definition of the PICO elements, we can really start to understand what it's going to be about and what are maybe considerations for vaccines. So starting with population. The population is defined as all the relevant populations and subpopulations identified by the member state. That it can be what is in the EMA label. It could be trial-specific populations or even specific subpopulations. So what does it mean for vaccines? So we know that national recommendations for National Immunisation Programme often do not cover the full population as stated in the label. So already there you might have differences across countries on actually what is a population of interest. Additionally, the population disease burden data, so epidemiological data, might not be available at the time of assessment, again, making it a bit harder for countries to truly understand and decide what is the relevant population in their case. And again, difference in epidemiologies, but also in recommendation will make potentially the needs and a comparison and a consolidation across member states quite hard. So then we move to intervention. Intervention is defined as what is going to be assessed. And in our case would be a newly licensed vaccine. So that's easy, let's say we know what it is. For the comparator, this is defined as alternative vaccines or therapies for the selected population against which the intervention should be compared. So essentially, if we think of a vaccine, there will be a new vaccine for a disease that currently has no preventive measure. Selecting a comparator might be quite hard because there will be not a true, let's say, comparator to be done. There might be treatments. And in general, again, similarly for comparators, as we discussed for population, there might be differences in epidemiology. That means that countries use different vaccines or different preventive measures, there can be different recommendations. So again, different products can be recommended across countries. And finally, there might be different seasonality. And all of this will lead to the fact that maybe the selecting of a given comparator for the PICO might not truly also reflect the technical characteristics of the vaccine. And this leads us to the last but not least important element of the PICO, which is the clinical outcomes. And so these are the outcomes that member states will identify as critical for the assessment. We know that for vaccines, the key clinical outcomes are vaccine efficacy and immunogenicity, and these will come from clinical trials. But already, as alluded before, vaccines are interventions that are given to healthy populations and for which some of the benefits, let's say the public health benefits, might not be evident at the moment of introduction, and it will only be available and evident later as the vaccine actually gets recommended and used by population. So this is to say that potentially at the first GCA, there might not be evidence on effectiveness, on the duration of protection of the vaccine, the impact on disease transmission of the vaccine, and in general, other elements. For example, Professor Postma mentioned of this more broader value vaccines concept that, of course, will be only apparent as the technology is used in healthy populations. If we go to the next slide, what I will do now is to maybe go a bit more in depth and thinking, okay, what does it mean to select a population and a comparator to inform a PICO for vaccines? And of course, you might also think, okay, but what about outcomes? It's very important. Absolutely. And this will be covered in the next case study. So if we think of selecting a population for a vaccine joint technical clinical assessment, as we said, let's say there will be different recommendations. So different countries as part of their national immunization programs will define who should receive a certain vaccine. Is it by age group? Is it by risk group? And also within which time frame? And these might really vary across countries. And similarly, for a comparator, the countries will be able to, I'm running over, I'll quick. And countries, similarly for comparators, will potentially recommend different products. And again, if we're talking about new vaccines, so targeting a disease for which there is not a current vaccine, you might need, let's say, it might be difficult to find a comparator. Quickly going to the next two slides are just to show you, this is the pneumococcal recommendation in some selected European countries, where you see that actually the recommendations are different in terms of at which age they're recommended, if it's a population-based or risk-based recommendation, but also for which products the recommendation covers. So again, it will be quite hard to identify a let's say single population and comparators. And if we look at the next slide for the meningococcal disease recommendation, we see that this is even a bit more complex for children and adolescents. So to conclude, in the final slide, we refer to the guiding principle on how, let's say the EU HTA framework can actually address some of the complexities we just discussed. And I think that the three main recommendations are really to develop feasible vaccine efficacy and effectiveness and safety comparison methods, to recognize the role in epidemiological modeling, to really inform the full clinical benefits of vaccines, and finally, to define clear clinical endpoints and safety assessment criteria so that comparisons actually can be meaningful and evidence can be rightly interpreted. Thank you very much.
Thank you very much, Eliana. I know it was difficult to outline all the complexities that goes with the scoping process and PICOs in such a short time. Hopefully we'll have time to go back to some of the questions that just pop up in the Q&A later on. And now, last but not least, I would like to invite Jessica Castelao, Director for CRR Pharma Vaccines and Oncology Alliances at MSD, to outline us some of the challenges that we will face when it comes to the real-world evidence and surveillance data collection.
Thank you, Anya. Good afternoon, everyone. In this section, we will to emphasize the importance of this real-world and surveillance data collection in the context of this future joint clinical assessment for vaccines. As Eliana mentioned, this connects directly with the PICO, and one of the main elements is the outcome. real-world and surveillance data collection, it's also important for medicines. But in the context of vaccines, exists a particular bunch of challenges that we face, especially when we are conducting the clinical studies for vaccines, because has been mentioned here, vaccines are for healthy people. This means that it has been designed for prevent diseases, and in the clinical studies, we face the uncertainty about if the participants will be exposed to the virus, for example. This complicates the measure, or also if it's challenging to know if the vaccination will prevent the transmission. It's because of that this real-world evidence, it's essential to demonstrate the value, the complete value of the vaccines, because vaccines as a preventive measures are impacting over many, many years. If we want to the next slide, please. It's crucial to understand the difference between vaccines efficacy and effectiveness. And you could say, yeah, efficacy, it's the ideal goal in the clinical studies, same for medicines, and effectiveness, for sure, it's in the real world, and it's facing broadly population and distinct situations. But in the case of vaccines, the limitation in the clinical trial findings and the gap between this and the real world performance are huge. And this is because some key factors, some of them has been mentioned during the presentation today, are affecting to this effectiveness of the vaccines. This is incidence, herd immunity, cross protection, strain circulation, the age, serotypes, even the duration of protection. It's because of that the real world data collection is crucial, and we are emphasizing today this importance to collect this data collection for the future joint clinical assessment. Next slide, please. We want to share here one of good examples that illustrates the unique role of this real-world evidence in the vaccine's effectiveness. HPV vaccine, I think that has been shown an impressive results in the clinical trials, but these results has been in the prevention of HPV infections. However, the real impact, the true impact of this vaccine has been the reduction in the incidence of HPV-related cancers. And this, it's a long-term benefit. It's something that we cannot capture in the clinical trials. Takes between 5 and 10 years after the introduction of this vaccine in the programs to capture this real impact. And it's clear that in comparison with the average of 3 years in the trials for efficacy, it's not enough to capture the complete value of the vaccines. Next slide, please. It's because of that here, in this case, the guiding principles apply to improve and to solve some of these limitations. The first recommendation, it's about the repository. It's about the EU guidance. The guidance related the collection of data, because we need to create consistency about the cross markets in Europe, and it will be easy to compare the different data. The second recommendation is about the development of a repository of successful case studies. This could allow the different stakeholders to learn from each other and to improve the data collection and the analysis. And the third one is the real-world evidence registers. This is really important because we need to harmonize the dedicated registers to track the vaccination individuals, the health outcomes, and the impact over the time. And this has to be in conjunction with encouraging between the private and public collaboration, because leverage the expertise of both is going to be crucial for improve the challenge that we are facing here today. Thank you, Anya.
Thank you very much, Jessica. That was super clear. So now I think I will invite all the speakers to come back for this Q&A session. So feel free to put your camera back on. We have a few questions that were asked. I might start with the easiest one. So there was one person who wrote, I'm still not fully clear when under the Act, joint HTA will become a requirement for vaccines. Is that 2030? So Maybe, Chiara, this is back to your presentation from the beginning. Could you clarify that for our participants so that at least one message they have clear from this webinar?
Yeah. Vaccines will be evaluated with the joint clinical assessment starting from 2030. In the meantime, there could be the possibility for companies to ask for joint scientific consultation that are a different kind of activity that can be asked for having some inputs on the developing and research activities on specific products. So it's ahead of the application for EMA approval, and joint scientific consultation can be accepted if the product is meant to be under the scope of HTA regulation, so will be addressed with the joint clinical assessment later on. And there is also space for voluntary collaboration. This is why we are here today also, I guess, to discuss how we can implement and support the development of methodological guidance for addressing vaccine specificities.
Thank you, Chiara. I hope that was clear now. So another question that we had was, let me just find it again, was linked to the monoclonal antibodies. Are you considering monoclonal antibodies when developing how JCA must consider vaccines? They are quite significant in the pipeline that was shown by Professor Postma. So believe we should be preparing. I was wondering, maybe Eliana, would you be able to respond briefly to this question?
Sure. Let's see if I understand the question first, but let's say if I understand correctly, the question is what about monoclonals and indeed as part of the vaccine zero pipeline. So as Chiara just mentioned, all the drug, let's say all the products EMA approved as of 2030 will be in scope. So monoclonal will also be in scope for GCA. Let's say what we have discussed so far, or the specificities of vaccines, I think can be more specific to preventive monoclonals. So there might be some areas of overlap, but not always. So I think the answer is a bit of it depends, but they will be in scope of the GCA.
Thank you very much. Okay, then next, there were two questions. I think they are quite similar, and that relates to what is the HTA coordination group doing at the moment when it comes to what we are just saying, so the vaccine-specific methodologies, processes, because one of them said that currently there don't seem too much efforts taken for special consideration of orphan drugs, vaccines, and so on. I don't know if anyone would like to respond to that. I'm also happy to do it.
Martin here. I'm happy to give a first response. I'm driving, so I keep my camera off, if you don't mind.
No.
And I basically agree with the person who made this statement that there is in vaccines, orphan drugs. I don't know, probably the same, but there is not so much going on in terms of harmonizing methodologies. And I think in my talk I did try to convey that I think there is a need to do that, and there is a need for collaboration. And from that respect, it is also a little bit a pity maybe that JCA will focus on the PICO, as Eliana showed, and maybe not yet so much on the type of methods that are crucial for vaccines, like the dynamic models and the discounting issue, for example, that I highlighted as well. So not much going on, and a big need, I would say.
Yes, thank you very much, Martin, for jumping in from your car. I think I agree, and probably this is also linked to the fact that the reality was that the HTA coordination group was very much stretched at the last months to make sure that all the implementing acts and methodological guidelines are in place for when the HTA regulation will become applicable, so from January this year. So this is why they might not necessarily have time and reflection space to think about, okay, and what about the specific products, how we will treat them, because this is something that will come later down the line, let's say. However, and this is exactly why we have this conversation today, because we hope that by having these discussions, we will raise awareness and ensure that those things are not forgotten, because they are written in law, that there needs to be some specificities considered in the joint processes and methodologies. I'm looking at other questions that we have. There is a question from Isabel. How do you envisage the HTA process for vaccines that address the same virus, but A, use different technologies like mRNA, and B, use different routes of administration, nasal, spray versus injection? I don't know if any of the speakers would like to respond to this one.
I can try. So, or Paolo, you wanted to go?
No, yeah, I think we can complement each other in a certain way. I think the complexity of the joint clinical HTA is will in any case consider the fact that different technologies in any case should bring similar outcome, or the objective of joint clinical HTA give some guidance which technology would be the best versus comparator, or to assess the real value behind this new technology. So I think how, for example, even the fact that one technology could be delivered in some way to the other, it could be evaluated through the real world evidence or through the RCT at first. But this is the same issue or the same challenge that every other medicine will have. So I think it's not really specific to vaccine with the homogeneous approach, rather than looking at the specific delivery system, for example. Please, Eliana, if you want to complement.
Okay, now maybe last question, or the one of the last, let's see. I have a question that relates to real-world evidence studies, so perhaps something that Jessica, you covered in your presentation. There is someone asking, how about the use of the real-world evidence studies in the vaccine methodology? Would it be applicable? Would you like to respond to this one?
Yes, Anya, I think that this is one of the things that we are aiming to take in account in the case of vaccines, because real-world evidence, as we mentioned during the presentation, it's relevant for medicines also, but in the case of vaccines, to the broader scope of the health population, herd immunity, the duration of protection has to be taken in account. And this is one of the things that we have in our route, and I think that clearly reflected in the principles that we published some months ago.
Thank you. Okay, I will go for a last one because I think it's an interesting one. Do you think that different approaches to disease prevention will be considered as comparators under the JCA? For example, will maternal RSV vaccines be compared against neonatal monoclonals? I think this is, Eliana, linked to your presentation. I'm sorry to calling you again, but... Of
course. And I think it is, let's say, in a different way related also to the answer Paolo gave. Essentially, the way the PICO works is about outcomes. And so different technologies might be compared if member states and the coordination group agree that PICO is relevant. And so there might be comparators, and comparators might also be vaccines versus treatment or vaccines versus nothing. So at the end of the day, it will really depend on what are the country needs. And at the same time also the availability of the evidence, because of course the clinical trials will have happened, and so some comparisons there might be no evidence, and it might be a bit too late to start a new trial to generate a specific evidence versus a given comparator. So potentially, yes, let's put it this way.
Thank you very much. I'm afraid we are running out of time, so I would like to thank all the speakers and participants today for joining us for this first discussion, and I think it will definitely not be done because we still have many questions in terms of how this EU HTA regulation will work for vaccines. So at some point we were almost 300 participants. That means that the interest is clearly there. I think what we can learn from today's discussion is that we definitely need to work together to find these right approaches and solutions to make the regulation work, because ultimately what also Chiara mentioned in terms of the objectives of the regulation, it is all about ensuring that we will have the population time to and population access to vaccination improved in the EU. So this is what we are aiming to achieve. Again, thank you for your participation, and I wish you a lovely rest of the day.
Bye-bye.
Thank you, everyone. Bye-bye.
Bye.